hello, my friends. It is a pleasure to be with you again. It's been a little while, but this is a topic you don't want to miss: the unexpected red flags of airway and oral dysfunction. Trust me, I get it. There are a lot of people who teach a lot of different things and everything about airway, and you should look at tongue ties, and you should look at the Malampati score, and you should look at this and look at that, and all these things that you really just genuinely don't have time to look for if you're in clinical hygiene. There's so much going on in hygiene within the United States of America, whether it be this shortage or what is spoken of as not a shortage, but just real deficiencies in our hiring system and what's going on in the offices. No matter where you stand on the spectrum of these things, I'm going to break it down in a way that is easy for you to understand, to grasp. Okay. So give me a hi, hello in the comments. Just let me know that you can see me, you can hear me, and I am not talking out into the void because that is the last thing I want to do. So, welcome. I am Carice Laguerre. I'm your Myo best friend. I come here to YouTube and on LinkedIn with so far over 60 hours. We're approaching really close to 70 hours of free education on all things myofunctional therapy. And there's nobody better for you to be learning from than me, because I'm always looking for the best in new research, the best in new things that I can share with all of you, because we need to upgrade to a level of excellence that we're not at right now. And we can only get there if we're working together. So work with me. Let's keep this going. Make sure that you're subscribed if you're following on YouTube. If you're following on LinkedIn and you're watching on LinkedIn, connect with me. I love to chat and get to know all of you. You really are my Myo best friends. Turn on all your notifications, comment, like, and share. All of those things expand the reach. The more people we have looking for this, the more help we can get to those out there who really need it. And that's what we need, is more access to care with myofunctional therapy and airway. Okay. And so as I started, let's jump right in. I know the first thing that everybody's thinking, and it always comes up every single time, is airway. What exactly is that? Even what does that mean? Now, people will talk about airway, and I think a lot of the time when you hear it as a dental professional, if you hear it as an external professional, if you're in a medical or healthcare or allied health field, you're thinking of airway as just the way people breathe. You're just thinking of it as you might have to put a tube down somebody's throat, open up their airway, and do chest compressions and do all these things if you're into CPR. But airway is so much more than what we typically give credit to, right? So a lot of times when we're talking about airway, we're only talking about sleep. And so people think that airway means sleep. If you do dental sleep medicine, you do airway, right? Makes sense. No. I think a lot of the dental sleep medicine people might even tell you that it's so much more than that they're working on too. Tongue tie. Ooh, I'm going to go on a rant today about tongue tie just a little bit. But tongue ties, it's not all tongue, lips, buccal, or buccal, however you're pronouncing it, ties. It's not all expansion. I know people think airway dentists are all expansion or sleep or tongue ties, and there's no in between. It's not all tongue thrust and open bites, okay? So when you're thinking of airway, you're thinking of that big velvet rope where there are all these expensive, fancy classes that you can take so that you can become an airway hygienist, so that you can become a myofunctional therapist, so that you can become a sleep coordinator, so that you can become a sleep dentist, sleep practitioner, whatever it is, right? But I'll tell you that airway does not always mean most of these things. And some of these are just scratching the surface of what airway can be, because airway is also this person that you might get in your dental chair, highly anxious, very nervous, orally defensive. They might have a hyperactive gag reflex. You're seeing these people all the time and you don't even realize it. We're all working in airway, and you don't understand that that's all a protective mechanism. That is how they are able to guard their airway. If they have a small or narrow airway, if they have small retractive or retrusive jaws, everything is going to be a protective mechanism. So some of that anxiety some of those people who you see on your schedule when you come into the office and you're like, oh my gosh, not today, Susan, right? Like you just know this is going to be a bad appointment, or you're just going to have to take so much extra time that maybe you don't have really in your schedule. That's your airway patient. Periodontal disease, we are all looking for it. If you work in corporate dentistry, sometimes you're looking for it more so than others. But periodontal disease is airway. It's all airway, not all airway, but airway is an important component that we really do undervalue. And we'll touch on that just a little bit more. TMJ, oral facial pain, you're missing all of these red flags. If you think that you're not doing airway, you already are. It is time to get airway aware, okay? And gastrointestinal issues, irritable bowels, having leaky gut, all of that, it's airway. You're seeing these people. You're seeing the manifestations of it. Oftentimes, you're describing it as something else. You'll have a patient who come in, who will be in your chair. All of a sudden, they got to run to the bathroom. Like, oh no, I got to go to the bathroom like right now. And you see in their chart they've got irritable bowels or leaky gut syndrome. That's your airway patient. If they also have perio, if they also have cardiac disease, if they also have audible breathing, like if any of these things are starting to come together for you, just know there are some red flags for airway that you might have missed your whole career, your whole career. And that is okay. That's what I'm here to help you with today, is catching all these red flags, because you see them, you didn't know them, and some of them you're going to be a little bit surprised with, because we're seeing some of these people and we're going through the medical history, because that's something you already have to do, right? So I don't want you starting to look at all these random things that you've never looked at before. You're like, what is a strain mentalis? I don't even understand what that means. I don't know how to classify a tongue tie. Good. I don't want you doing any of those things. You don't have time for it. And there's nothing I hated more as a clinical hygienist than somebody coming in, doing a whole like lunch and learn with us and trying to get me to do extra work that I'm not paid anymore for. Like, you want me to do more work with a little bit of time that I have, and I'm not getting any sort of reimbursement for it. So I understand you want airway, if you're going to do airway, to fit into your schedule as it already is. And I promise you, if nothing more than medical history, you're going to learn a lot today about some of the things that you can be catching as red flags, and take those red flags and notify your patients, and we'll get more into that. All right. So you ready? Give me a yes in the comments, like, hey, I'm here, I'm ready, let's go. Okay. Here's how you're going to get your MyOIs. This is just a small bit of what we'll be going over, but there are going to be glaring red flags, super obvious red flags. All of those sleep and tongue ties and like narrow arches, high vaulted palate. Yeah, typical glaring red flags. Those are the big old stinking red flags that you can't possibly miss, and that you understand from whatever you do understand, whether it's from a continuing education course you took at the last state conference, or whether it's from watching YouTube videos here. Like, you get these signs. There's going to be the middle of the road ones where it's like, oh yeah, I may have known that, but I forgot. Or this is a good thing for me to start picking up on. And then there's going to be all of those low key red flags, the under talked about, under discovered, undiscovered. Some of the, I don't think they're undiscovered. They're just a little low key. These are not the big red flags. It's a tiny little red flag, and it's waving right in front of you. And now you'll be able to understand that it is related to oral myofunctional disorder, or oral facial myofunctional disorder, whatever you want to call them. OMDs are what you're really, really looking for. And it's an oral dysfunction. And as dental professionals, and even as those in allied health, you can look for and identify some of these things, because some of these things, even if you're just looking at the graphic with that adorable little boy there, if you're looking at that graphic and you're seeing like, oh yeah, there are some things that I would see in my office as an allied professional. Dental professionals just know it as oral dysfunction. Okay. So an OMD is an inability to utilize proper oral or facial muscle function. It's characterized by overuse or underuse of the muscles when breathing, when just at rest, when relaxing, when doing absolutely nothing, being clenched in your posture. Now you're overusing some of the muscles of mastication, right? So that type of correlation I want you to start getting together, okay? It's not just what's happening, as in like they're clenched in posture. It's not just the breathing, as in like the mouth is open. Well, when the mouth is open, what muscles aren't being utilized? Because that would be an under utilization of those muscles. So start getting our thinking caps on in that wonderful way, but while breathing, while chewing, and or swallowing. Okay. And so OMDs are what you're really looking for, because OMDs are going to manifest as all those things that you're going to see, as some of the red flags, the big red flags, the lip incompetence, TMD, dysfunction, which is probably like a mid red flag, unilateral mastication, which I would probably say is going to be a low key red flag, because these low key red flags, you're not even looking for them in the office, but sometimes you notice them just based on the wear on the dentition, or sometimes the difference in the cheeks when you're feeling them, when you're trying to retract, like you understand what's happening. It's definitely always manifesting as parafunctional habit, a tongue thrust. It can manifest as a number of things. It really doesn't look the same for everybody all around. What you might see from your look into their medical history is some issues with speech or gastrointestinal problems, GI issues, sleep breathing disorders, which is an umbrella term. And I want everybody to get used to that it is an umbrella term that encompasses a lot of things, from primary snoring all the way through to obstructive sleep apnea. Like, it's a number of different things. Upper airway resistance syndrome, which is not its own separate diagnosis. I need everybody to start understanding that, because that's not a thing, although there are certain characteristics of it upon which you can distinguish that from obstructive sleep apnea or mild obstructive sleep apnea, which might be the actual diagnosis that a physician gives. You might be able to look at the studies and to show and demonstrate to your patient that there's something else going on. Okay. Psychological disorders, anxiety, big one. Anybody who's heard me speak before, you may have heard me say, what's the very first thing that happens if you go to a psychologist or a psychiatrist and you're diagnosed with anxiety? What's the very first thing they do? And if you know, put it in the chat. Even if you're watching the recording, throw it in the chat. Just challenge yourself a little bit, because it's one thing to just sit and idly watch. It's another thing to like really be involved. But what happens? They give you breathing exercises. Like, I know a lot of you want to put in prescriptions and so forth. I get that. But they give you breathing exercises. We've known for a long time that breathing, respiration, like all of that has a very close association with anxiety and can help regulate or dysregulate if it is thrown off in any way, shape, or form. Depression is very similar, not to the same extent, but very similar in the correlations. Orofacial pain. There's a lot of different consequences of having an orofacial myofunctional disorder or an oral myofunctional disorder. Okay. With that being said, all right, let's start diving into a couple of red flags. Because you're looking for oral dysfunction, and that's really what's manifesting, but it is coming out as mouth breathing, glaring red flag. I think we all know the nose is for breathing, the mouth is for eating. That's it. I don't have to talk more about that one. We know that that's a glaring red flag. If you see somebody in your chair or in your op that has their mouth open at rest, and even if it's just a little part. So I know we love those models that we always see. They're in the magazines and they're just lips apart. Yeah, I know. I wasn't schmizing there, right? And they're just lips apart. It's not how you want your patient to be at rest. That is not how we want them to be actually breathing. At rest, beautiful faces, our lips closed, okay? Lips closed all the way. If there is a gap in between those lips, then you can put your perioprobe there if you want. But if there's a gap between those lips and it's, 2, 3, 4, 5, 6, anything less than closed, glaring red flag. sleep disordered breathing if they are aware and if they have already denoted that. So if they have obstructive sleep apnea, they've been diagnosed, or they know that they snore, or they know that whatever, they have these specific things, glaring red flag. Tongue thrust, because we're always looking for that, and that always seems to be like the very first big red flag that a lot of people see or note in our field. Tongue thrust, particularly when associated directly with an open bite. Now, sometimes it's not always an open bite. Sometimes it's just flaring. The more that I am on TikTok is really starting to change my whole algorithm. Now, you've ever been down a TikTok rabbit hole? Because I know I surely get on those TikTok rabbit holes where I'm seeing a lot more dentists who are on there who are talking about all things airway and expansion, and then don't talk about function and like changing dysfunction, which automatically discredits you in my mind. Like, you have to talk about both or talk about neither. You can't just sit there and just talk about, like, oh my gosh, you have to do this and expand. And then once you expand, you're going to be boop, magically better. That's not the way it works. Function does not change just by, making a structural change. Just like a lot of people in airway like to say that if you take the tonsils and the adenoids out, you don't just automatically become a nasal breather with proper oral resting posture, right? So if you just expand the palate, you don't just boop magically become a nasal breather with proper oral resting posture. So function is a very important conversation to have. However, I got on this kick because of tongue thrust. Okay, so in my TikTok scrolling, what I've discovered is that there's a lot of people who have these issues that they're putting out there. And so TikTok's feeding me more of these videos. I'm seeing videos of people who are adults getting tongue cribs in, getting tongue tamers in, which in and of itself always leads to a bigger problem. I spoke to a mom just the other week who I told her before she went to put in this oral, this oral appliance, it was a tongue rake. Before she went to put in the tongue rake, don't do it. I know you don't like that your kid sucks their thumb, but if you put in this rake, it is not going to do anything positive. It is going to reinforce a negative. So, no, don't put your thumb in there. It hurts. But where are they exactly supposed to be able to stimulate their palate otherwise? You can't answer that question. Your kid can't answer that question. You're going to wind up with a new problem. And the new problem is now that there's like this habit that is negatively replacing where we're chewing on skin and all sorts of things. And it's driving them insane. You don't have to get there. Okay. Not as a child, not as an adult. You can change function. Is it the easiest route? No. I could go and get lipo if I'm not happy with the way my body looks. I can go to a plastic surgeon. Sure, they can fix it. But if I keep my same diet and exercise and stress levels and sleep and whatever, nothing's going to change. I'll go right back there immediately after. So the easiest route is not always the best route just to go there. But with the tongue thrust, I'm seeing more of these people. I told y'all I was going to get on a rant today, okay? I'm seeing more of these people who have these appliances in. And then I'm seeing more people who have perio, where they're like, we're losing our anterior maxillary teeth because they start flaring outwards, and it's like really severe perio. And my mama had this perio, and my grandmother had this perio, and my great grandfather had this perio, and it's all genetic. And I'm going to take my child to an orthodontist early on so that we don't have those problems. Okay, make sure you get them functional training also, okay? Because we can see that that tongue is pushing out those teeth in every single photo you've posted, from you being a baby through you being a like adult. We're seeing the dysfunction in all of the photos. Where is your tongue in every single one? Pushed right up against those teeth as you're smiling there in these photos when you're 2, 3, 4, 5, 6, 28. Like, we're seeing that. So that should have been something that was caught and a glaring red flag a long time ago. It's not always open bite. That was all to get there, y'all. Can you believe that? I know. Y'all really are my best friends if you're still listening after all of this. But it's not always open bite, but tongue thrust is a very, very big thing. Malocclusion. If the teeth ain't right, the function ain't right. Like, that's it. Point blank, period. We're just going to put an exclamation mark on that instead of just the period. We're just going to emphasize it. Okay. Tethered oral tissues, which I'm about to get started on my next rant, so just, bear with me. Parafunctional habits, which is any maluse of the oral cavity. The mouth is for eating, right? So is it for breathing? No, that's a parafunctional habit. Okay. Is it for your lip to be sucked in there? No. Is it for your cheek to be there? Are you biting your cheek? No. All of these are parafunctional habits: mouth breathing, tongue sucking, thumb sucking, lip biting, lip hooking. Like, doing any sort of thing that's not supposed to be done with the mouth is a parafunctional habit. You're seeing a lot of that as they're just idly sitting in the chair while you're going over your medical history. These are glaring red flags. Orofacial pain is a big one because a lot of times it's just muscularly involved, overuse or misuse of these muscles. Compensations, recruitment patterns, like all of these things are glaring red flags that your patient probably has a deeper airway issue going on, and it could be causing systemic problems. So we're looking at just these little one-off things, but as we get into the low-key red flags, I'm telling you, you'll start to see it more as like what's going on systemically with them. Asthma as well, also allergic rhinitis, like all of these things, glaring red flags. Okay, people talk about them a lot, but let's touch on tongue ties for a second, because I can't be in Facebook groups anymore. I can't stand when somebody makes tongue tie everything, when it's like the only thing in the world that matters. Here is the soapbox that I'm going to stand on, and I'm going to stand on it quite firmly. Okay, so get ready. Tongue tie is not NOT with a capital NOT, not a causative factor in oral myofunctional disorders, oral facial myofunctional disorders, or whatever you want to call them. Okay, it's not a causative factor. Yes, you have an issue with your structure, but does everybody with a tongue tie manifest the same things? No, the research isn't even conclusive on that. And we would be remiss as evidence based practitioners, okay, if you're a dental provider, if you're practicing in your licensed specialty. We are only a licensed professionals if we are practicing in our licensed specialty and it's evidence based. That's how we got to the education that we got, the standardized education. It's based on evidence based things. We would be remiss to stop acting like evidence matters. There's not enough evidence that tongue tie is directly causing speech issues, directly causing whatever. There can be a lot of correlation, but not everybody with a tongue tie has speech issues. And not everybody with a speech issue has a tongue tie. And so these are not directly related. And tongue tie, I want y'all to stop looking at it as something that you see and, oh my gosh, worst thing ever, we have to get rid of it. Because we're no better than the ENTs who think every bit of tonsils and adenoids needs to be surgically extracted. That's not the way it has to be. Every bit of tongue tie doesn't have to be released. Every lip tie doesn't have to be released. Every buccal tie doesn't have to be released. These are choices. Now, can you compensate really well? And that's what a lot of people are going to say. They're going to push back, but people are compensating really well. So it is a problem. Okay, they're compensating really well. How does compensating really well impact them functionally? And there's larger conversations we can have about that, where we really would sit down in like a discussion based forum and be able to go back and forth with it. But I will tell you 100% without a doubt that you will not find tongue tie definitively being a causative factor for all the many things that we're like, oh, tongue tie is so bad, it just has to be whatever. It's overdiagnosed because everybody's looking at it from structure. I want people to start thinking critically as evidence-based professionals and start looking at function. Where there is dysfunction and a tongue tie, let's have a conversation. But there's not always dysfunction in a tongue tie, and there's not always dysfunction in people who don't have there's not always proper function, there we go, in people who don't have tongue ties. Okay, so let's not be remiss. Let's not let go of our scientific thinking caps. Just because myofunctional therapy in and of itself is not an evidence-based profession, because it is eminence-based, if you don't know the difference, please hit me up. I promise I will help you understand the difference. But just because it's not evidence-based doesn't mean that some of the things that we work with and people who we work with don't need to still follow these inquisitions and all of the hypotheses and continue to test and test and test. And we need to find these answers. But for right now, we don't have them. It is not causative, it is correlated, but not causative. Okay. Sorry for bursting that bubble. While we are still on that little nugget of a trail with our glaring red flags, periodontal disease is a big one that I would like to address right now because we never really get too deep in it. I do like hover on the surface. But when we have these parafunctional habits, we know bone responds to loading. We know that because of the osteoblast osteoclast relationship. And every healthcare professional who is watching this, and I understand that some of the public, the general public, watches this too, and you watch me in awe, and people, they wind up booking consultations with me and they tell me about all the things that they're like, I didn't understand what this word was. I get it. I get it. Just follow along, okay? But every healthcare professional, you understand this osteoblast osteoclast relationship. When there is bone loading, the osteoblasts and clasts, whatever, will have the breakdown. Got it. And then we have a little bit of the buildup and yada, yada, yada. Okay. So that's going to cause extra loading with parafunctional habits that are like clenching and grinding and some excess chewing. Some people do a whole lot of chewing. It's an excessive load. So we have additional bone loading on top of your eating and so forth, and you're doing the tasks that do require the teeth to be in full occlusion. But that's going to add an undue pressure onto your periodontium, okay, and the alveolar bone, and that will create some gingival inflammation. It will also create some vertical bony defects. So those vertical bony defects are going to happen. Inflammation of the gingiva. Now suddenly it's not holding on as tightly to that bone, and suddenly that bone is not as high or as quality as it was, and that creates a perfect breeding space, a perfect breeding ground. And that's what I want you to think about it of, because those anaerobic bacteria that we all associate with periodontal disease just sit. They rest, they nestle in there, they get all comfy and cozy. It's like you've built a whole new community for them to come in. You've built them like a downtown metropolis. And so you're inviting so many of them there. And so we have all these people who we will treat with scaling and root planing, or they might get flap surgery, or they might get, you name it. They go through the whole protocol, and you cannot stabilize their periodontal disease to save your life. You're trying so hard. They might be even trying so hard. They're brushing, they're flossing, they're buying all the things. They've got all the fancy schmancy stuff that we can possibly recommend to them, and nothing. It's really not stabilizing. They're coming to see you more frequently, but we're still getting that vertical bony loss, and we're still seeing an increase in some of our probing depths, or we're seeing more recession of the gingiva, and we're trying to figure it out. Did anybody take a look at function? Is anybody trying to resolve what's going on with the parafunctional habit? And once we start addressing that, I think that'll be the biggest glaring red flag that dentistry can ever do for periodontal disease, to help people address from both ends their dysfunction, yes, and all of the biomechanical contributors to periodontal disease, in addition to all we do with scaling and root planing and, you know, antibacteria directly into the source, or perioprotect, or whatever, all that stuff that we do for the biochemical component. And we can put all that together and make it just a beautiful arresting to periodontal disease progression, for real, for real. Okay. I love these little charts. I actually have taken a couple of these slides with these little charts directly from the Airway Hygienist Academy. That is the course I am so phenomenally proud of. The level of research that is in there, and the slides and the depth of which you start to learn these correlations. I can't even express to you. But like, if this little bit is giving you an inkling, it might be something for you to look into at Rehygienist Academy. We'll talk more about that later. Mid red flags. So, it's not a glaring red flag. You may or may not have known about this association, but for sure, you're aware that it might mean something, like gut dysbiosis. Leaky gut is a process of inflammation. Oftentimes, mouth breathers may have the additional, all the additional bacteria and things that get into the gut. It cause additional inflammation within the walls and the linings of our intestines, and that inflammation is now going to lead to more permeability, which means now more stuff gets out. Leaky gut. I mean, that's what it is. Irritable bowel syndrome, very connected. Aerophagia, very connected. GERD, acid reflux, super connected. You're going to see a wonderful graph on that and how all of that is connected. But anybody who comes to you that has gastrointestinal issues, red flag for airway. Like, start thinking airway, okay? Orthodontic relapse. You know what really grinds my gears? People who swear that if they have like a bar that is like a lingual bar that you just put in there, that that's the end all be all, that nothing shifts afterwards with the lingual bar. And that might be the majority of cases, but there definitely are some that definitely do shift afterwards. I wonder what that could be. That's really weird. Why would it be shifting? The retainers that are removable, whatever, there are people who wear those religiously and things shift. There are people who don't wear their retainers and sometimes don't have any shift. You know, there's all spectrums to that. But orthodontic relapse, why is there not stability in the dentition? Well, because everything has a little wiggle room, right? Everything is kind of moving and shifting. And so things are just trying to shift back to where they were, right? It's because you haven't established a homeostasis between your body and the soft tissue pressures and all of the changes that you've made in the hard structures. So changing the structure doesn't automatically change the function around it. And therefore, you're going to have that disharmony that is going to create undue pressures in one direction or another, be it intraoral, creating a negative pressure, or extraoral, creating a negative pressure. So, like all of the soft tissue, your tongue, your cheeks, your lips, if they're not creating the proper pressures around that dentition, you're always going to be subject to moving. Always. There are constant light pressures working against you and your retainer all day and all night. So I don't care what retainer you made. Okay? We've got some bodily forces that completely outrun that. So anybody with orthodontic relapse, that needs to be a red flag that you're really starting to like, whew, yes, I need that. I need to make sure that I'm checking for that. Anxiety. Anxiety, we talked about it. A lot of the anxiety goes and correlates well with the breathing and how we are respirating. So when we're not breathing appropriately, we're not able to regulate our autonomic nervous system. Did you know that at rest, your tongue should be in a light cave, a light cave. Oh my gosh, it should be in light suction against your palate. So it should be in light suction against your palate. And when it's there and it's able to stimulate and talk to your vagus nerve, which is where we help to regulate our autonomic nervous system. And so that is our fight or flight, sometimes our freeze, sometimes our friend, and our social abilities, our ability to socially engage, our ability to regulate between these zones gets altered when we don't have our tongue in proper rest or if we're substituting. So a lot of people are like, oh, the thumb, it's just for comfort. Oh, the pacifier, it's for comfort. Well, how can we give them another way to stimulate that same comfort? Maybe perhaps by teaching where the tongue should go or teaching positive things and not just putting in appliances that are going to prevent you from doing the right thing in addition to prevent you from doing the wrong thing and teach you that your tongue should go nowhere except for maybe back and fall into your airway and make your sleep and your life a little bit worse. Diabetes, oh, diabetes 100% for sure should be a mid red flag. Now, diabetes as like type 2 diabetes, definitely I don't know that the research is there for type 1, but for type 2, absolutely. So let's take a look at GERD, and then I think we're going to take a look at diabetes. And if we don't take a look at diabetes, I promise I will explain it to you, because the diabetic association, correlation, I should say, with diabetes is that you'll have a higher insulin resistance, which is going to now decrease the impact the glucose can have on your body. But let's talk about GERD or reflux for a second, okay? So a lot of times when you're not breathing right, your body's got one job: keep you alive. We can go for days without water, weeks without food, but none of us can go for any more than a few minutes. Even some of those deep divers in those scary documentaries that we watch about those people who go under and they're diving down for like close to 10 minutes and then they come all the way back up and they practically die on the way back up. None of us can go but for a few minutes without air. Okay. We need to be able to breathe. So when we are having these instances at night where we're not really breathing appropriately, well, we've got oxygen desaturation. The body's got to wake us up and it's like, hey, get up. You need to live. Stop dying on us. And so you'll wake up and you'll have this intermittent sleep disruption. And that sleep disruption or fragmentation is really just a lot of what goes along with some of the reflux or the associations based on some of the research about reflux and how it correlates with everything. You're going to now have negative intrathoracic pressure. That negative pressure is going to lead to your lower esophageal sphincter dysfunction, LES dysfunction. It's easier for me to say less dysfunction. It's going to lower the esophageal dysfunction, which is going to now kind of open it up and lead for these acids that are otherwise contained to now come up the esophagus, okay, which is your acid reflux or your GERD. You'll kind of get yourself back into that, relaxed state, maybe go back to sleep, and you might get it all over again, especially when you're lying down. When you're lying down, it's an easier pathway than when you're upright because of gravity, for obvious reasons. So GERD is going to be a big red flag eventually as you guys start to notice it more, or reflux is going to be a big red flag, okay? I thought I was going to talk about diabetes, but we'll talk about diabetes in just a second because it looks like I put it in two sections. Low key red flags. Okay. These low key red flags I think are super important for us to kind of march through. Nobody's talking enough about eczema, allergic dermatitis. Like, we don't talk enough about that and how breathing or oxygen desaturation or inefficient breathing does lead to more flare ups. There are some people who are very much aware that eczema and asthma highly correlated. If you're not breathing appropriately, we're going to have some bigger flare ups with our eczema. And a lot of times in airway and the work that I do as a myofunctional therapist, I see the exact opposite, where we start getting them to breathe appropriately. And now suddenly those eczema flare ups that were so big and so massive in their lives are able to come down. Okay. Bedwetting, especially above the age of 6. So under the age of 6, like, let it go. Every now and then it happens. If it's happening every single night at 4, 5, and 6, like, you could probably go and get that started to get addressed, because if it's every single night, that's an issue. But if it is intermittent below the age of 6, probably not an issue. But bedwetting, and most times, and this is why it's a low-key red flag, is because a lot of adults, they're not going to tell you about it. They're not going to share with you that they wet their bed occasionally. They are not going to tell you that they had a very lucid dream and they thought that they were at a bathroom, at a toilet, and they were sitting down, that they were really using the bathroom, and they wake up in the morning and they're covered in their own urine. They're not going to tell you that unless they're really close and they feel like it's a very safe space. But more often than not, you'll get, yeah, I wake up frequently to go to the bathroom, which may be very, very true. But a lot of the bedwetting, when we have the oxygen desaturations, it's going to signal, it sets off different hormone responses, and it's going to signal to the body that we've got too much sorry, not potassium, if you've got too much sodium, we need to release sodium, and we need to release it now. Let the bladder go. Let it go. Or wake up. The bladder needs to be emptied. And they get up and they go to the bathroom. So a lot of the times where, and I'm guilty of this too. I have 4 kids, and one of my kids wet the bed every single night through the age of 10. Every single night. It was the most frustrating thing. We limited drinks. We limited like the time, how many times you can go to the bathroom before. Like we were really, really trying to be on top of it, and it didn't matter what we did. We were like, wake up and just go to the bathroom. Like we thought she was lazy. No. A lot of times they're still very much in a form of sedation when they are releasing the bladder, and they have no idea that the bladder is releasing. Sometimes it turns into that lucid dreaming, like I talked about for adults, where they think they're in the bathroom, but that's not what happens. And it's okay. We can work through it. But a lot of times it's a low key red flag because nobody's going to talk to you about it. And if they talk to you about it, it's with a lot of shame, and it's a conversation you have to handle very delicately. Okay. Autoimmune disorders. Okay, y'all, you ready? I hope you got a pen and a paper. If not, hopefully you're watching this on the recording. If you're watching me live, then you'll need to come back, okay? Because I'm about to give you a nice little list of things that you need to be looking for as far as autoimmune disorders. Rheumatoid arthritis is going to be at the top of that list. Okay, rheumatoid arthritis, heavy associations with obstructive sleep apnea and so forth. Psoriasis, and psoriatic arthritis. Also, the same with breathing and breathing disruptions and sleep apnea and the higher correlations. Sjogren's and overlapping the fibromyalgia that accompanies that. Okay. Very big associations. A lot of the Sjogren's, they're already complaining of the dry mouth and so forth. Like they have that already, and it is exacerbating the sleep issues that they're having. And a lot of this is just like a bi-directional relationship, to be totally honest. A lot of autoimmune and oral myofunctional disorders, orofacial myofunctional disorders, and general inability to properly utilize these orofacial muscles are very much correlated. Hashimoto's, myasthenia gravis, these are big, big red flags that once you're used to seeing them as red flags, these autoimmune things are very much correlated with what we do in airway. And sometimes we can help to diminish the amount of um, I was going to say discomfort, but I don't feel like there's any way to make the comfort better. I mean, lupus is even a part of it, and there's so many, it's so multifactorial, but how they're addressing it with traditional means of management along with alternative methods of management, I think does help to improve their quality of life. There we go. Okay. So autoimmune, you want to start looking for those disorders. It is very bidirectional. A lot of times when you're mouth breathing, you increase the amount of inflammation that happens in the body. And so you have an autoimmune disorder, especially one that's associated with inflammation, you're going to be more prone to having these flare-ups or increased instances of these autoimmune effects. But please start looking and asking more questions as soon as you see that on a uh, medical history. Chronic inflammation, I think I just kind of doubled down on that when I talked about the mouth breathing and instances of inflammation. The inflammation can extend all the way up through the airway. If they're chronically inflamed in a lot of different ways, there's a multitude of things that are possibly going on, but airway is probably one of the things they might be struggling with as well. Cardiac disease, oh my gosh. With cardiac disease, we have so much issues with the oxygen desaturation and then the dilation of these blood vessels. And if you've got parafunctional habits on top of that, then you're more likely to have a morning headache because of the dilation of the vessels, particularly within the cranium. And on top of that, you've got the overuse of the muscles of mastication, the temporalis, and so forth. Now you've got like this slamming headache every single morning because you've been struggling all night and the oxygen desaturations have gotten to you in a way where some people can't even explain it without the bruxism. With bruxism, without bruxism, it really all is about the dilation of the blood vessels within the cranium. Whew. airway is so much more than like a tongue tie and poor sleep. It's got so many different tentacles or arms or extensions, branches of a tree that you can just pop, 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 pop out more. Difficulty with weight management. We're going to talk about that in just a section. Difficulty with reproduction for women and for men. With men, there is the issue with the testosterone. Sometimes their testosterone, it's not going to be as prominent if they're struggling with sleep disordered breathing. And testosterone replacement therapy, we talked about this in a different lecture, but testosterone replacement therapy can be contraindicated because it can increase sleep apnea in addition to, not just being as effective as it was, but testosterone, you can have that be lowered, and that'll lower some of your abilities, to be as productive when it's time to engage in activities. So erectile dysfunction and so forth. But also for women, it can definitely, affect and play a role in your hormones and your cycles, and therefore cause issues with reproduction. Okay, let's get into diabetes real quick because I promised you diabetes. Sleep, airway collapse, fragments head sleep. So you're waking up more and more, and you're not able to cycle through your sleep stages appropriately. Okay. So you're not getting restorative sleep in any way, shape, and form. That's why you may be in bed for 8 hours. You wake up and you're like, oh, I feel groggy. I feel terrible. Like I am not ready for the world today because you didn't get restorative sleep at all that night. That's going to decrease your glucose tolerance because you're increasing your insulin resistance. And then that cardiac muscular strength is going to stimulate autoregulatory mechanisms, which are going to really lead you back into an issue where you can't navigate or manage your diabetes, your insulin, and the insulin loads or your glucose as effectively. Okay, so your insulin regulation, it's not where it should be. But weight management. Okay. I hate talking about the HPA axis and having to like pronounce everything, but let's talk about it. The HPA axis, the hypothalamic pituitary adrenal axis. These are all connected. The hypothalamus secretes a hormone, and the pituitary gland secretes another one, and these all talk to each other, and the adrenal finally will release one, and that's related to cortisol, which is, we know, related to stress, right? So when we have disrupted sleep, it's going to increase the oxidative stress, which is going to lead to more cortisol being flooded through the body. And I think TikTok is wonderful for a lot of things. You can do a whole lot of exercises, and you can do those somatic releases, and you can do a whole lot of things to help like reduce or regulate the cortisol. I think there's even some supplement. There's some supplement that they say can help to decrease the cortisol, but I'm telling you, if you're getting fragmented sleep, you're going to have more issues than those, pills or exercises can resolve. But that's going to completely alter or stop in some places, like between the communication between the pituitary gland and the adrenal gland, or it'll ramp up and it might skip the it might skip the pituitary, and the hypothalamic is producing, and the pituitary is not, but the adrenal is. It's going to now initiate a fight or flight, okay? Because now you've disrupted that axis. That axis is going to slow down your metabolism, which is also going to increase the amount. You ever woke up and you're like, oh man, I could go for something really sweet. Like, oh man, I could go for something really salty. Oh man, I could go for something. Yeah, your HPA axis might be off. Okay. I am your sweets girl. Okay. So trust me, no shame here, no judgment. But if you've ever wondered why you might be having some issues with weight management, you might be doing everything right during the day, and you're like, oh, I just keep a couple of Skittles by the bed because every now and then I want, a little something sweet inside, just whatever. Your HPA axis is off. It's probably slowing down your metabolism. You have too much cortisol going on. You're probably not getting fully restorative sleep, and your body is storing more fat because you're in a fight or flight, and we might need this fat for something. And so you're struggling with your weight management. So sometimes you might wake up and feel like, oh my gosh, am I like bigger today? Like I just don't understand what's happening with me in my body. No, Just me? Okay. Sometimes it's related to this HPA axis, I'm sorry, related to that. And so just be very, very mindful when you have people who say that they have unexplained weight gain, or they don't really know where it's coming from, or they don't really know why some of the things that they're doing aren't helping. Like if they are active and they're exercising and they're dieting and they just don't understand what's happening, start to question or ask more questions about sleep. Okay. Now, I know you're thinking to yourself, I'm curious, what am I supposed to do with this information? Okay. Like, I can't do anything with this. I have understood, okay, there's all these things I need to be looking for, like, but I don't have time and I can't do this. Well, I want you to take can't out of your head. You can do it if it is just doing something about it. Just being aware that you're already in an airway and there's more that can be done. Okay. And it doesn't have to be crazy. Keep it simple, but make it amazing. Okay. Just keep it simple. All you got to do is start looking for like little things. All right. So little things. And then you can come back and you can go back into all of those red flags and start looking at things. You want to look at their posture, whether they have forward head posture or rolled forward shoulders, or their mouth is open, or they're biting on their lip, or they have any sort of, you know, dysfunction going on. Okay. You could start by looking at them when they're in the waiting room before you've even gotten them in the op. Then you have them in the chair and you're looking at their medical history. I mean, mouth breathers have higher blood pressure. So you're taking their blood pressure, start looking at their mouth and oral rest posture. Sleep apnea, if they're telling you they have sleep apnea, if they're frequently congested, if they have orofacial pain, if they have periodontal disease, like when you're looking at their medical history, you're going through even your own chart notes, their dental history, what is going on that could be a red flag that you identify. What's going on in the op? Malocclusion. Are you finding that there is what looks like a tie, but who knows? Are you finding that they have a scalloped tongue, that they have a gummy smile, that they have narrow, vaulted palates, that their tonsils are really large, or that you can't see their uvula? You can find all that stuff in the op without taking any additional time. And then once you do, just ask a question, okay? How would you rate your sleep? This is what I do. I give everybody my little sleep scale. Okay. So I ask them about a sleep scale. How would you rate your sleep on a scale of 1 to 5? Where 1 is you can't remember the last time you had a good night of sleep. You wake up every morning or most mornings feeling unrefreshed. Where 5 is the exact opposite. You can't remember the last time you didn't have a good night of sleep. Every night is great. You wake up feeling amazing. How would you rate your sleep? And I want you all to do this right now, just to think about it for a second, like how you would rate your sleep. And then my next thing is to just provoke an answer that will get them talking. So it's open ended after that. Okay. So let's say they give me a 2. Okay, 2. First of all, I'm going to write that down. Okay. That way you could ask them next time, should that become a standard in your practice and how you are managing all this airway stuff in your daily duties. But um, 2, why did you choose the number 2? Well, I don't know. I just find that I make verbal diarrhea. I feel most people are going to give you a lot of information, unless it's the 5s. If they're like, it's a 5, like I really get good sleep every night. I feel great. I got this new mattress and whatever. But that still is a whole different type of verbal diarrhea. But there are going to be questions that you don't think to ask about their sleep, and things that they would never even realize are associated with why they picked that number, that are going to get them to kind of give you information that you wouldn't have otherwise asked about. They might start telling you about their sleep position. They might start saying that, oh, I wake up and I have peripheral neuropathy. So I wake up sometimes and I just can't feel my fingers and I feel unrefreshed. And is any of that related to, like, did you find something in my mouth? It opens up a conversation and it gives you more details than you can take time to sit down and ask every single question, right? So you just want to give them something provocative that is going to get them going. And then what do you do with that? You can always refer them out to a myofunctional therapist. Where do you find a myofunctional therapist? Good question. Really glad you asked. You can find a myofunctional therapist on any number of directories. But here's the thing with directories are exclusive in nature. Like, if you're not a member of a certain organization or you haven't paid to be on a directory, you're not going to show up. So yes, you can go look at airwayhygienists.com, hygienists with an s.com, and you can go through the directory from the International Association of Airway Hygienists. You can look at the AAPMD directory. You can look at a bunch of different directories. But if people aren't members, they're not going to show up. Does that mean that they're not worthy or not fully educated? They may have just chosen not to join those particular organizations. Okay. So what I would do, any myofunctional therapist, worth their weight in gold, has a Google business listing. If they do not, I don't know that they're worth their weight in gold, because that seems like the simplest thing you can do to be found so that you can help the most amount of people. And if you don't feel confident yet that you can help the most amount of people with your myofunctional therapy services, then you probably wouldn't list yourself on Google, right? So Google is a verb. You will Google the myofunctional therapist near me and you'll find people. I've never met a myofunctional therapist that doesn't want to talk about myofunctional therapy. There aren't a whole lot of us who are out here who are practicing proficiently and full time, but those of us who are, we are absolutely without a doubt practicing confidently and putting our businesses out there. So we will come, we will talk to your office, we will talk to you, we will let you know how we like to be referred to, if there is some process or whatever, what things you can say that will likely get patients to come our way, what our pricing is, if we're flexible in that pricing, do we have any alternatives or any sort of anything else that can help to supplement the burden that it might create financially on some of the people in your practice, particularly if you have like a Medicaid practice. So find a local myofunctional therapist. If you can't find one, call me. You can always find me at themyospot.com, okay? Or level up your abilities. Like, it's you now. Like, you're the professional. You're the person, okay? I promise you this slide is coming back because it will go away in just a second because we're not done yet with my lecture. But you can become an airway hygienist or a myofunctional therapist. These are two completely different things. An airway hygienist would be in the practice, actually utilizing, in some cases, dental insurance and medical insurance and being able to bill out for local limited services. Okay, so it's like a triage, being able to do some intermediate care while the myofunctional therapists take care of like the big things. All right. Either way, one of these links is going to give you a discount, but I promise you it's coming back. Okay. Because wait, there's more. Not everybody's going to be excited about what you're talking to them about. In fact, there's going to be a good portion of people who are like, no, I don't know why you're talking to me about this. I'm just here for you to clean my teeth. I'm just here for you to whatever. Like, I am not here for whatever this sleep stuff is. My sleep is fine. Leave me alone. Okay, Karen, no problem. Like, they're not that into you. You could take a hint. That's fine. I would just remind anybody in that situation, that's what I always do, is that I'm an educated professional and I go above and beyond what the state mandates. So they want me to take a certain number of CEs and they have to be in a certain number of topics, right? But I go above and beyond that and I get more. I, on my off time, am learning about ways that I can help to enhance patient care. And in that, I'm discovering this brand new world of things. So I've taken what the state wants as 40 CEs, and I get about 100 every year because I'm always looking for more. And so in that, you're just highlighting to them the professional that you are, and it's okay to wait and see. And some of those people actually just might need more information, and you're going to be the person to lead them down the rabbit hole. So don't be afraid to watch and see, like, hey, we'll just hang out and like, you let me know what your sleep score is next time I see you, and if you see any changes. But here's what I want you to look into. There are some books, there are some resources, there are some websites, blogs, whatever. There are things that you can look into that you can learn more. So whether it's any of these books that are here, Breath, James Nepster is very, very highly talked about. A lot of people really, really love that book. It goes into a lot of the science. Sleep Wrecked Kids by Sharon Moore is a fabulous book if you have kids. It really does highlight the pediatric airway, like that whole path. Airway is Life. Airway is Life is really good for like the whole family and kind of understanding how everybody is impacted by all of this. And I think Sharon Moore and Dr. Dasani really do break it down in easy to understand ways. Dr. Dasani has a fabulous podcast. I did her podcast. Um, I did her podcast. I was trying to remember the name of it, but I did her podcast, and it's just absolutely fabulous. And so, even if they're not into books, like the podcast, and then Accomplished, which is a book I wrote, and I'm telling you, it's just barely over 100 pages. I'm all about brevity. Like, let's get to the point. I hate to see a 300-page book because I know I'm not going to finish it. I'm going to start it. I'm going to get about 150, maybe 200 pages in, and then I just start skimming, and I'm just over it. Like, you can get to the point in so much less time. I don't have the attention span for it. So Accomplished really breaks down a lot of this really, really well. All of these books you can find on Amazon, and it's really an inexpensive way to get your patients the information that they need. Or you could just curate your own list. You can have a QR code. It doesn't cost you anything to get a bit.ly or to get a QR code from certain places, and just put together it maybe in a Google Drive or in a Dropbox or somewhere that is safe or you feel good about it. You can have links to your favorite blog on Airway, your favorite websites, your favorite YouTube videos about Airway, your favorite articles, whatever, and just make it really easy to access. That way, they can scan it right from your op, and they already have all the information. And so if they want to do the deep dive, they can. And that's what's really the powerful thing, is having that information, being able to own a part of learning more about their bodies. Okay. So you know better now. At this point, you know better. And if you feel like you're ready to do better, then do better. Start having those conversations with your patient. Start looking into who you can refer to if you're not interested in getting in it yourself. Start putting together resources and information for your patients. They deserve it, okay? They've been looking into all of this, and they need you as their advocate, okay? And if you're ready to do even more, then do more. Okay. You've got links there. Oh, links there. Okay. It's been fabulous being with you today. And I look forward to seeing you the next time that we up level the field by learning just a little bit more and being able to push that care outward so that more people get the help they deserve. Bye, best friends. I'll see you next time.